Hello and welcome. As we have all been learning, the COVID-19 pandemic has been caused by a novel coronavirus that spreads between humans primarily through droplets of saliva or nasal discharge when an infected person coughs or sneezes. COVID-19 can cause mild to moderate respiratory illness, followed by recovery without requiring special treatment. However, older people and those with underlying medical problems like cardiovascular disease, diabetes, chronic respiratory disease, and cancer are more likely to develop serious illness and possibly death. Since the initial COVID-19 outbreak, well over 220 million cases have been reported worldwide, with over 4.57 million related deaths. As we've also been learning, the COVID-19 pandemic, measures to control its spread, and COVID-19 disease itself has had pervasive effects on how society functions, with particularly harsh impacts on health and healthcare service provision in virtually every region of the world. As with many other areas of health, the COVID-19 pandemic has had a profound impact on people suffering from acute and chronic pain that are pandemic-related, as well as related to COVID-19 illness, including emerging evidence of new COVID-19 related pain syndromes. The International Association for the Study of Pain has struck a presidential task force on COVID-19 and pain with the objectives to collect, coordinate, and provide timely information to IASP members and patients on the possible impact of COVID-19 in relation to pain. As part of this effort, IASP has launched this series of webinars on the latest on COVID-19 and pain, starting with today's first webinar, which I have the pleasure and honor of introducing. Hello and welcome. As we have all been learning, the COVID-19 pandemic has been caused by a novel coronavirus that spreads between humans primarily through droplets of saliva or nasal discharge when an infected person coughs or sneezes. COVID-19 can cause mild to moderate respiratory illness, followed by recovery without requiring special treatment. However, older people and those with underlying medical problems like cardiovascular disease, diabetes, chronic respiratory disease, and cancer are more likely to develop serious illness and possibly death. Since the initial COVID-19 outbreak, well over 220 million cases have been reported worldwide, with over 4.57 million related deaths. As we've also been learning, the COVID-19 pandemic, measures to control its spread, and COVID-19 disease itself has had pervasive effects on how society functions, with particularly harsh impacts on health and healthcare service provision in virtually every region of the world. As with many other areas of health, the COVID-19 pandemic has had a profound impact on people suffering from acute and chronic pain that are pandemic-related, as well as related to COVID-19 illness, including emerging evidence of new COVID-19 related pain syndromes. The International Association for the Study of Pain has struck a presidential task force on COVID-19 and pain with the objectives to collect, coordinate, and provide timely information to IASP members and patients on the possible impact of COVID-19 in relation to pain. As part of this effort, IASP has launched this series of webinars on the latest on COVID-19 and pain, starting with today's first webinar, which I have the pleasure and honor of introducing. This webinar will now start with a presentation by Abrahão Batista. Abrahão Batista has a background in physiotherapy at the Brazilian Institute of Rehabilitation Medicine, with a master's in 2005 and a PhD in 2007 in morphological sciences at the Federal University of Rio de Janeiro, also in Brazil. He has also completed a postdoc at Western Sydney University in Australia in 2014. Dr. Batista is now an associate professor at the Federal University of ABC in São Paulo, working in a multidisciplinary team of neuroscientists with different backgrounds to understand the brain of patients with chronic pain and how to use non-invasive neuromodulation as an adjunct to exercise in their treatment. During the COVID-19 pandemic, his group started to investigate patients with severe COVID-19 at the intensive care units and also in the post-COVID condition, using neuromodulation to improve respiratory symptoms, pain, and fatigue. Please go ahead, Abraham.
Hello, I am Abraão Batista from the Center for Mathematics, Computation and Cognition, Federal University of ABC in Brazil. And I'm going to speak about physical activity and exercises in the management of acute COVID-19 related pain and fatigue. I do not have any conflict of interest regarding this presentation. Well, since COVID-19 pandemic has started, many patients with chronic pain did not have adequate access to treatment, to health facilities, or some others developed pain and fatigue related to the disease. Our colleagues in the University of São Paulo investigated a group of patients that were get into the hospital because of the disease and compared them with a group of controls who entered the hospital at the same time but did not have COVID-19. They assessed these patients for pain, and what they saw is that patients with COVID-19 present pain at the head, headache, and at the neck mainly, and also in the lower limbs comparing to the control patients. We know that patients with chronic pain many of them increased in severity and also in pain interference, showing that the disease itself or the conditions, social conditions related to the disease contributed to these characteristics. These patients decreased their access to healthcare facilities, and so they decreased their access to massage therapy, physical therapy that includes exercises and much other therapies such yoga, for instance, or occupational therapy. And between the services that they did not have at that time, exercises are between the most important. And these patients say that as they didn't have access to exercises in their facilities, this contributed to increase in their pain. So it's clear that exercise are important therapies for pain and fatigue. And here, these patients show that this was a very important question, a very important issue during the pandemic. Another study in Brazil and including other centers in Europe, tried to understand the effects of the lockdown in the behavior of physical exercise, pain, and psychological well-being. They evaluated more than 3,000 patients in these countries, in Brazil and other European countries. They saw that the majority of the participants of this study were in social isolation, mainly because they could not access their jobs. And this table shows that the level of exercises changed after the COVID. So if you see here, there were the number of patients, the participants of the study, more than doubled that were now sedentary during the COVID-19 pandemic. And also the ones who were very active diminished this level of activity. It's interesting to see that frequency of exercises changed. The duration also changed. The type of exercise changed. Participants started to use more aerobic and resistance exercises than strength exercises, probably because they could not have access to their gyms. And fatigue increased, and also motivation changed. This other study showed the same, almost the same thing, but now with athletes, handball athletes. What they showed is that the days a week these athletes went to vigorous physical activities decreased. The mean time on minutes per week also decreased. And the mats they were used to spend also decreased. The same happened for moderate physical activities and walking. And interesting but logical, they spent more time sitting than previously. Exercise can contribute to the risk factors of COVID-19. This has not to do exactly with pain and fatigue, but here we can see in a very large number of participants from this study, the classical risk factors of COVID-19 being a man, an older man with increased body mass index. But interesting, this study shows that it's a risk factor for hospitalization for COVID-19 to be consistently inactive or inconsistently active. This means people that do not do exercises regularly. So these conditions contribute to hospitalization, to intensive care admission, and in a lesser way to death. This study also shows something very interesting. This is a cohort that was being followed in Brazil for another objective. And during the pandemic, part of these members of the cohort got COVID-19. So this group wanted to understand the impact of exercises and physical activity, that if these factors contributed to being a patient of COVID-19. what they saw is that the level of physical activity really contributed to this. So patients that were more physical active, that spent more meds for each week, and even that did more than one exercise, were more protected than those who were less active. And also, it's possible to see that even muscle mass or muscle strength contributes to be a protector or not for COVID-19. The study showed that with a very simple measure of muscle strength through a handheld dynamometer, that participants with more strength tended to be less days in the hospital due to COVID-19. What can explain these findings? There are many explanations by which exercises and physical activity can contribute to health, and in this case, to protect for pain and fatigue in COVID-19 disease. But one of these hypotheses has to do with the cytokine storm that presents in patients with severe COVID-19. So the coronavirus 2 infects cells through the ACE2 receptor, and the macrophages start a cytokine storm that can sensibilize nociceptors. Nociceptors and the dorsal root ganglion, and also nociceptors in organs like the pulmons, the lungs, or the respiratory tracts. And because of this cytokine storm is not stopped by the endogenous mechanisms, the disease tends to be severe. So this infection, this cytokine storm that is not stopped by endogenous mechanisms, involves a dysfunctional activity of the efferent vagus nerve activity. So patients with obesity or hypertension or diabetes, they tend to have a less efficient efferent vagus nerve activity and consequent control of inflammation. So it is fair to think that exactly this mechanism can be approached by exercises, as exercises or physical activity increase vagus nerve efficiency in the control of inflammation. We also know that exercises tend to switch the phenotype of macrophages from macrophage 1 to macrophage 2 phenotype. And this macrophage 2 has an opposite activity than macrophage 1. The one is inflammatory, and the macrophage 2 phenotype is anti-inflammatory. So probably this explains the relationship between exercises, physical activity, and the protection for COVID-19 in most of people. For fatigue, it's not different. Probably fatigue has to do with a GABA metabolism impairment that is related to the systemic inflammation. And so pain and fatigue share probably the same mechanisms in the pathophysiology of the disease. These results indicate that probably exercises are important to control pain and fatigue in the majority of the population. But the problem is not the person who likes to exercise, because the person that likes to exercise will exercise in their homes or maybe in the streets, but protected with masks. The big problem are those persons that do not like to exercise. Well, there are some studies that assess the sedentary behavior in patients, in athletes. Athletes can train even 3 or 4 hours a day, but when they arrive their homes, they sit and they have a sedentary behavior. Trying to counteract this behavior, some studies have investigated the use of small changes in the sedentary behavior at home or at the workstations. They studied did this, so they tried to counteract this by asking people to move each 30 minutes during this 5-hour period. So one group stayed seated for this period and the other group stands up and moved for a while, 1-2 minutes for this time. And what they saw is that the fatigue score of people who moved during this period was less than those ones who didn't move. In another study, they compared people who stayed seated for 240 minutes to people that moved each 30 minutes for 2 minutes in these 240 minutes, or people that moved for 8 minutes 3 times in this period. And what they saw, their outcome was cerebral blood perfusion. And what they saw was that the group who underwent this 2 minutes walk each 30 minutes had increased perfusion in the brain. This again has not to do exactly with pain and fatigue, but probably these are strategies to help people who don't like to exercise to maintain an active behavior and so maybe protect against pain and fatigue. So in summary, COVID-19 increased the burden of pain and fatigue in some people, not all the people, and this may be associated with changes in physical activity levels. The decreased physical activity levels are associated with increased risk for severity, for complications in COVID-19, and this can be counteracted by increasing exercises for those who like to exercise, or even increase physical activity and by counteracting the sedentary behavior at home or at work. So thanks for this opportunity. I hope you think this pandemic can boost our search for a sense of life and help us to understand and treat and help patients who are suffering.
It is now a pleasure for me to introduce our next presenter, Dr. Nigel Knox. Dr. Nigel Knox joined Westchester Medical Center in June 2018 as a pain management physician and is currently an assistant professor at New York Medical College. Dr. Knox earned his respiratory therapy degree before attending St. George's University School of Medicine. He completed his residency in anesthesiology at New York Medical College, serving as chief resident in his final year. Dr. Knox went on to complete his fellowship in pain medicine at Johns Hopkins. Dr. Knox continued on to become a pain medicine specialist and anesthesiologist, specializing in non-opioid based interventional pain management techniques to alleviate patient suffering. Dr. Knox offers a compassionate and comprehensive plan for optimal pain treatment for a variety of painful conditions. Please go ahead, Nigel.
Good morning. My name is Nigel Knox, and today I'll be presenting on acute and early post-acute pain in COVID-19. I'm an assistant professor in the Department of Anesthesiology and the Pain Management Division at Westchester Medical Center, a Trauma One training hospital in New York, United States. I'm also the director of Knox Pain Management Medical Practice and have no conflicts of interest with this presentation. Severe acute respiratory syndrome coronavirus 2, the novel virus that causes coronavirus disease 2019, COVID-19, can affect nearly every organ system. Although the main clinical signs are related to respiratory function, SARS-CoV-2 is also capable of infecting cells of the cardiovascular, gastrointestinal, musculoskeletal, and neurologic systems. As we are all aware, the global pandemic has significantly affected our healthcare systems, providers, and patients, and has cut across all geographical specialty and socioeconomic boundaries. These unprecedented times in healthcare have created the need for clinicians to expand well beyond their usual practices to address the rapidly changing needs of patients with COVID-19. This was not seen more than at Westchester Medical Center, as the ever-changing medical needs required the formation of a strong medical response. The pain management and anesthesiology teams quickly transitioned into a COVID response department and subsequently developed a COVID hypoxic response team. It is this experience that led to the direct observation of patient presentation, care, and treatment plans, but subsequently led to the review of a patient's pain presentation and treatment. The significant COVID-19 patient exposure allowed for a review of patient assessments, particularly their pain, and medical response. It is through this information that we were able to collaborate with 2 other training hospitals and allowed for the formation of a multi-center study. Our study incorporated the findings from teaching hospitals in the United States, Westchester Medical Center in New York and Johns Hopkins in Baltimore, and Korea, the Seoul National University, between February 1st, 2020 and June 15, 2020. In this multi-center prospective study, data on the intensity and type of pain were collected on 169 patients with active severe acute respiratory syndrome coronavirus 2 infection. The primary objective of the study was to determine the prevalence and breakdown of pain symptoms among patients with COVID-19 infections who were admitted for non-pain symptoms and the association between the presence of pain and intensive care unit admission and death. We asked whether acute pain or pain exacerbations could be a marker for disease severity. It was through this investigation that we were able to identify commonly associated virus-induced pain presentations, pathophysiology, and approaches to care. This study allowed us the opportunity to review treatment options that were provided during the acute response period. Among this 169 patients reviewed, 38.5% reported an active pain condition. Among the patients with pain, the most common pain symptoms were headache, 30%, chest pain, 23.3%, and spinal pain, 24.7%. There were other conditions as well: myalgia, 17%, abdominal pelvic pain, 17.8%, arthralgia, 15%, and generalized pain at 12%. After review, we found that pain intensity was not significantly associated with ICU admission or death, and was not a marker for virus virulence or burden. Even with the identification of significant pain presentation in comparison to other COVID pain studies, we still found decreased rates in comparison to previous viral illness reports, which we believe to be due to the more established virus environments, methods of surveillance, and improved patient questioning. I can speak to this personally, as pain often was not a priority or focus during the acute infectious period. We actually found that individuals without pain were more likely to require intensive care and expire than those with pain. The reasoning as to why pain may be associated with reduced mortality included that an intense systemic stimulus, example respiratory distress, might distract pain perception, or that the catecholamine surge associated with severe respiratory distress might attenuate nociceptive signaling. In this study, we found that a substantial proportion of patients admitted for respiratory distress and other viral-related symptoms experienced significant pain, presenting with a wide variety of chronic pain symptoms. At this point, we have recognized that the vascular component of COVID-19 plays a significant role in symptom presentation. Some of the mechanisms potentially contributing to explain the high risk of thromboembolic complications observed in severe forms of COVID-19 are local inflammation, hemodynamic changes, and the induction of procoagulant factors driven by the enhanced systemic pro-inflammatory response. Vascular endothelial injury leading to disseminated intravascular coagulation has also been proposed as a potential subjacent mechanism involved in a state of hypercoagulability based on autopsy findings showing microthrombi in the lungs. With this in mind, through our study, we postulated the possible other mechanisms behind COVID-induced pain, with psychological, nociplastic, deconditioning, and virus-induced effects believed to be key components. We're going to reflect on some of these possible mechanisms over the next few slides. The studies by Li et al. In 2020 and Zhu et al. In 2020 identified the similarities between the pathogens SARS-CoV and SARS-CoV-2, which allowed for the discovery of the pathogen's viral structure and infectious mechanism. With this development, they were able to identify the interaction with angiotensin II receptors, ACE2, which are abundant on the cell surface of various human organs. This activation generates pro-inflammatory reactions whose landmark is the cytokine storm, a key component for alterations in the neuronal tissue and the endothelial tissue attached to it. In the study by McFarland et al., they identified ligands that have the potential to modulate sensory neurons in humans after severe COVID-19 infection. With this, the impact of cytokine storm must also be considered as a potential driving factor for the development of neuropathies after severe infection, and could contribute to the development of chronic pain after acute COVID-19 infection has resolved. Another major component in the patient's pain presentation that I personally observed frequently was the psychological factors associated with COVID-19. The effect of psychological factors in the development of persistent pain and disability has been well established on many different disciplines, pediatrics, orthopedics, and psychiatry. Identifying these factors and understanding the impact of psychosocial function could help improve patient treatment outcomes and prevent negative outcomes, including increased physical disability, increased rates of depression, anxiety, and decreased quality of life. A significant number of COVID-19 patients continue to have symptoms related to COVID-19 after the acute phase of illness. This post-COVID condition is sometimes referred to as post-COVID syndrome. With this in mind, Gardis et al. In France created a single study assessing post-discharge persistent symptoms and health-related quality of life for patients hospitalized in a COVID-19 unit following more than 100 days after their admission. Through the study, they were able to identify that many symptoms persisted several months after hospitalization from COVID-19, with post-admission pain and psychological issues remaining a persistent aspect of the patient's care. On the diagram, you can demonstrate that pain discomfort and anxiety and depression were some of the primary findings in the post-discharge patient. This was further identified by Moreira et al., who created a literature review in Brazil. They carried out a comprehensive analysis of the psychiatric and neuropsychiatric repercussions of COVID-19 based on epidemiological, pathophysiological, and clinical foundations, and reviewed the effective therapeutic interventions that may be utilized to assist with the virus-related neuropsychiatric developments. The psychiatric and neuropsychiatric symptoms of acute respiratory syndromes can appear during or after the infectious stage. The sentimental aspects, such as loneliness, boredom, frustration through isolation, and concern for family health, applied another level to the psychological burden. In this same manuscript, there is a significant relationship associated between post-traumatic stress and risk factors such as the presence of avascular necrosis and distressing pain after infection. Self-management and coping strategies in isolation will be reviewed in the lecture at 11:30 tomorrow. But from my direct observation, this was a significant aspect of the patient care that was undertreated during the acute infectious period. We'll take some time just to review some of the treatment options in the pain presentation in acute infectious period. So we're going to revert back to our own study, and we're going to look at some of the treatment options that are available for pain presentation during the acute infectious period. 17.8% of patients with pain were prescribed opioids, including 6 who received oral morphine equivalent doses of 50 milligrams per day or greater. 8.2% received adjuvants, 81% received NSAIDs or acetaminophen, 2.7% received muscle relaxants, 5.5% received a ketamine infusion, and 13.7% of patients with pain received no analgesic therapies. Patients with sickle cell anemia were more likely to receive opioids than those with other conditions, whereas those with arthralgia were less likely to receive NSAIDs or acetaminophen. So when we talk about the treatments and therapies, there was a lot of apprehension in this time period and a lot of concern by providers about utilizing pain analgesic therapies. In March 2020, non-peer-reviewed anecdotal reports emerged linking NSAIDs to exacerbation of COVID-19 illness, which led to warnings against their use by the World Health Organization and some national health agencies. This is a position that has since been refuted, with no strong evidence that NSAIDs must be avoided in all patients with COVID-19. Clinicians must weigh their choices on an individual basis, as they usually would. Some patients received opioids, which have well-known respiratory depressant effects and may inhibit one's ability to cough. Adjuvants such as antidepressants and anticonvulsants were administered only in a small number of people because few people had non-radicular neuropathic pain, and adjuvants had scant evidence in regard to radiculopathy. Antidepressants, gabapentinoids, muscle relaxants, and opioids all act centrally to depress the nervous system and may increase the likelihood of opioid-related complications, including respiratory depression, again providing apprehension to providers during the acute period. Ketamine is a powerful non-opioid analgesic that maintains minute ventilation at therapeutic doses, but may precipitate arrhythmias, angina, and cardiac depression. The direct cardiac depressant effects, particularly in patients with catecholamine depletion, may have been a concern during this time. Some studies hypothesize that tramadol might be a promising adjuvant therapeutic option against SARS-CoV-2 infection. Anti-inflammatory effect of tramadol may help to suppress the COVID-19 related cytokine storm through decreasing interleukin-6, tumor necrosis factor alpha, and C-reactive protein. Cardioprotective effect by a decreasing lactate dehydrogenase level, which is elevated in most patients with COVID-19. Tramadol, as an effective analgesic and antitussive, may have a beneficial effect on COVID-19 patients suffering from cough, headache, aching, and pain. The tramadol antipsychotic effect may also protect against psychiatric disorders associated with SARS-CoV-2 infection. However, despite their risks and all the associated risks with these therapies, which can be minimized or eliminated in a controlled hospital setting, the risk of undertreating pain may be more consequential. Poorly treated acute pain has been shown in an observational study to increase the risk of persistent post-injury pain and has a long-term psychological consequences, including high rates of anxiety and depression. Review of post-infectious chronic pain syndromes has demonstrated evidence that severity of pain during the acute illness may increase risk for neuralgia. The way that we should be approaching these patients' care during the acute pain in COVID-19 patients is initially treated like we usually do and as we teach through a biomedical approach, looking at the etiology of the pain and treating it. However, realistically, after review of all of our aspects and mechanisms of pain, the biopsychosocial approach, identifying the biological, psychological, and social factors, is preferable, particularly in this unpredictable and uncertain time. In summary, the impact of COVID-19 has affected all aspects of life on a global scale. As clinicians, we've had to adapt to this ever-changing environment. During the acute infectious period, the most common pain symptom presentation has been headache, chest pain, and spinal pain. We have to understand that there are multifactorial etiologies of these associated pain, and the approach to this should be taken from a biopsychosocial approach with reflection on the psychological, the deconditioning from the immobility, and the viral direct effect on tissue. However, a collaboration as a discipline and review of evidence will be the optimal approach to attain control in these uncertain times. Thank you for your time.
Well, thank you very much for that excellent talk, Dr. Knox. We're now very much in the live portion of the webinar. We were live earlier, but they were pre-recorded presentations. First of all, I want to welcome everybody again to this webinar. Thank you all for coming, and a huge thanks, of course, to ISP and all the members and leadership of the ISP COVID-19 task force. Thank you for that. I'm very, very proud of our first two presentations of this webinar series by Dr. Batista and Dr. Knox. And we are certainly very keen to have an active discussion about these presentations, and any questions from the audience are very much welcome. And so please go ahead and start entering your questions through the presentation system. Just to start off, Dr. Batista, I wanted to ask you the important research that you have done already very early on in the pandemic has illustrated the serious negative impact that a pandemic in general, but this COVID-19 pandemic in particular, has had on patients with acute and chronic pain. And unfortunately, given the way things are emerging, there will be a possibility of additional lockdowns in the future and continuations of restricted access to the various types of pain and rehabilitation therapy techniques that you've described in your study. And as we go forward with some uncertainty, I wonder, in terms of lessons learned, how you think that these continued barriers can be overcome, and what strategies have you started considering, and should we be thinking about all around the world to try and maximize access to pain treatment, exercise, and rehabilitation therapy to our patients during the pandemic?
Hi, Ian. Good morning to all. Thank you for the question. I think there has been new studies showing that video strategies to teach people how to exercise or how to be active are being very important to this. And I think this is an important strategy. Also, I've been seeing in outpatient clinics that there are some patients that they had COVID and now they have fatigue, but they are prone to exercise, or they say I can exercise, but I still feel that it's hard to start. I think the problem is not those patients, but there are a set of patients that when you ask them even to imagine that they are exercising, they have symptoms of fatigue and tachycardia. And these patients, I think this is a bigger problem. We are investing in simulating the prefrontal cortex, and we have seen some good results with this, but I don't know how to do this at home with patients. So this, I cannot answer completely this question.
Okay, thank you. Dr. Knox, congratulations. Well, first of all, thank you for a great talk, and congratulations on the important study that you've done on acute pain in the setting of COVID infection. I wanted to ask you about the literature that is available on acute pain presentation in other critical illnesses, other respiratory illness that requires intubation and intensive care. And do you think from the results of your study, do you think that the pain presentation that you observed in your participants, was that a generic pain response to critical respiratory illness, or is there evidence to suggest that this is more severe than a generic illness or something that's more COVID specific?
The last line, I apologize. You said pretty much, is it a generic response or more COVID specific? Is that correct?
Exactly.
Sorry. And as I kind of mentioned a little bit earlier in my presentation, it's absolutely, with COVID, it was just such an unpredictable and uncertain time. So a lot of my research, the numbers that we actually looked at in regard to the presentation, the pathophysiology and the treatment plans were more of a retrospective review of everything. During that time, it was such an uncertain and unpredictable time, it was hard to ascertain the true presentation of pain. So when we do kind of review some of these either viral illnesses, we have found that higher levels of pain presentation during them. But again, these are established illnesses, established viruses. And the way that we were actually more of with the establishment came a more stable environment and an ability to question the patients. When we talk about the study that we did, this was in a time when we really had no understanding of the true disease and what was going on with it. And the precedent was actually put on the respiratory component and obviously the systemic components. So pain was kind of an afterthought, to be honest with it. So when we reflect on it, I believe that the study itself showed that in the 30s for the pain presentation would actually be much higher, which we often see in other studies. Other COVID pain-related studies have actually seen lower numbers. So we have had the higher level because we've had it over, believe it, over a multi-center review, which I feel has had a better reflection on the true presentation of it. But I feel that we actually underserved the pain presentation. And if we were able to have a better reassessment in a more established environment, we'd find higher numbers. I do feel that the aspects of pain associated with COVID-19 are specific to it in the sense that the psychological components that are associated with COVID, the direct viral infection, as we spoke about in regard to the ACE inhibitor, that can be seen in other studies with other respiratory infections. However, COVID was so specific to itself in the sense that the environment that was surrounding these individuals and these patients with the isolation that they were created in, the psychological strain where they were away from their families for months, where they were being prone and had no reserve. I mean, it often took 30 minutes to take a patient from a supine to prone position because of their decreased reserve. So the severe levels of disease incorporated in conjunction with the actual psychological component, I think was very specific to COVID-19. But again, with establishment and understanding of the disease itself, I feel in time we could return to a place where we have better control like other viral diseases. I just think it was so uncertain at that time. That's what made it so specific.
Okay, thank you very much. We have a question here. I will just read the question out. It is from Meredith Porter.
who is an occupational therapist in Blackburn, England. Thank you, Meredith, for your question. I'll just read it out. I work closely with many patients who have been diagnosed with long COVID-19. Have you any advice for therapy strategies that we can give to patients experiencing pain in this setting? Thank you. Perhaps, Abraham, do you want to give a first shot in that, and perhaps Dr. Knox as well can respond?
Yes, thank you for the question. I think, again, the prefrontal cortex may be an important target to this to manage this condition. The prefrontal cortex is related to cognitive flexibility, cognitive inhibition, and also it's important in the modulation of fatigue and pain. So I think at home or even at outpatient facilities, it would be important to train functions of the prefrontal cortex, such as motor imagery, motor inhibition, cognitive flexibility. This may help these patients. We have seen some cases where it helps, and especially puts the patients in an active condition to work with their symptoms.
Thank you. So just to maybe bring it to Meredith's question, probably in a physiotherapy or occupational therapy setting, in dealing with a patient who has, let's say, a grade 8 education, how do we verbalize or explain that to someone who doesn't understand advanced neuroscience, and what are perhaps common, therapeutic techniques that are being used that could harness the impact of the prefrontal cortex in that setting?
Maybe explaining that it's important to train a top-down control from your brain to your body, and this may be achieved by controlling your mind, such as playing some games like Stroop games that you may control your mind, or train the possibility of doing things in a different manner daily, or even imagining some movements that the person thinks that are not possible right now, or are very difficult right now, such as I cannot run right now, but I can imagine I'm running, or I can observe people running. These strategies train the prefrontal cortex, or the top-down control of pain and fatigue and so on.
Okay, thank you, Dr. Batista. Dr. Knox, you've obviously had an interest in treating pain in patients with COVID early on, but perhaps even into the long haul setting. Do you have any advice for Meredith in England?
Absolutely. I actually think that Dr. Batista's approach, the occupational therapist and the physical therapist, is the primary component in a patient's treatment. When we speak about treatments and medications, again, we always look at the etiology of the pain and try to return to that and kind of isolate and minimize the treatments to the patient's pain presentation, as we always do with every patient. However, for me, the recovery itself was so significant. I'll speak of one example. I actually had a physical therapist and who was a marathon runner, who was a COVID patient during the pandemic's height. And his deconditioning over such a short period of time was so significant. And so when Dr. Batista talks about the kind of transitioning back and the optimizing the mental components of it as well, even if you can't do the physical components, that was something that we were doing. And again, I don't speak to the level of Dr. Batista, but we were using games, we were using mind goals, small victories or periods of time for patients to recover, as physical therapists and occupational therapists do on a regular occasion. But the issue with it, after I spoke to some patients afterward, that 6-7 months afterwards, they still haven't recovered to full in regard to conditioning, and they still require low dose oxygen therapy at home as well. So it's such a prolonged period of time. So I think that the psychological component also has to become a factor of this as well. That multidisciplinary approach, of course, the medications for the etiology of the pain, the therapist themselves working on the reconditioning, but also the psychiatrist and the psychologist working on actually getting these people through this time period as well. Another major issue with this, though, post-COVID, was a lot of these people, as Dr. Baptista spoke to, were unable to get this therapy. They were all closed and none of the physical therapists. So a lot of my patients went without physical therapy for 6 to 7 months. So what we did is like to try to restructure the telehealth visits and video visits to really put a strong focus on this, because I really believe this is the primary direction for the recovery as well.
Great, thank you. I have two related questions. I'm going to sort of combine them, and this may be a bit of a loaded clinical and a research question, but Heidi Kruklis from Brazil is asking if there are any hypotheses of how long neuropathic pain post-COVID lasts and whether this is just a temporary phenomenon. And Miguel Moreno from Chile is asking, what can we expect from the coming years after this pandemic in the matters of pain? So I'm going to sort of take a bit of moderator's license and combine those questions. And first I'm going to ask, because I know that long-term research studies are expensive, you're required to have staff along. And so my first question to both Dr. Baptista and Dr. Knox, we'll take Dr. Baptista first, is how long have you planned to follow the cohort of COVID patients in your study? Are you planning, and do you have the ability to continue following them in time? And do you have any response yet as to whether there's any resolution in pain and what we can expect for COVID-19 survivors?
This is very interesting. I'm always thinking about some conditions that were controlled, but they were still there, such as a diabetes that was not associated with neuropathy. And after COVID, it started to be associated with neuropathy only because of the stress of the body and so on. So I think neuropathic pain, many types of neuropathic pain may have worsened because of the infection and the post-infection condition. And we are now coming again to start a cohort with outpatients, but we were following only patients in the hospitals because the outpatients services were closed because of the need of the health team in the hospitals, inside the hospitals. So we plan to follow these patients for 2 or 3 years, outpatients for 2 or 3 years to see what happened. But they are increasing too much in numbers. And I think it will be very difficult to follow them, all of them, to have a really efficient outpatient program for every patient, at least in Brazil.
Okay, thank you. Dr. Knox, perhaps you can share with the experience from your study and how long that's going to extend.
Absolutely. Well, our study was done over 3 centers: Johns Hopkins in Baltimore, Seoul National University in Korea, and Westchester Medical Center in New York. We really just looked at this short period window with the acute COVID infectious period. So realistically, there's no plans to follow these patients in regard to that. I subjectively have done that with my own patients, some of them that I actually became very close with during the treatment of COVID itself. So I've had this kind of non-specific kind of follow-up with them, but I have seen the longevity. The follow-up has been a very short, very slow recovery in that aspect. However, I have reviewed a lot of these studies in regard to the long haulers or the post-COVID syndrome and all these other terms that have been coming up. And it's quite interesting because even if a patient was to take a test in regard to a COVID, they would come back negative. However, they're still having this presentation aspect. And there's been a lot, I know that Johns Hopkins was looking at this as well. There's been a lot of patients that have had risk factors for COVID infection, diabetes, smoking, high blood pressure. However, none of this has been related to the kind of post-acute sequelae that's associated with COVID-19. So a lot of the studies that we're looking at right now are more looking at the presentation in that post period. But I think the bigger factor in question, and more studies need to be shedding light on, is whether we need to find out why and who and what. So at this moment, we really just believe it to be secondary to an acute illness, as we would with other severe illnesses. But the comparison, and as going back to the question you said earlier on, the specificity with being COVID-19 or coronavirus is not identified as of yet, but I think that the more research is going into it right now.
Great. Okay. Well, thank you. The next question relates to, I think, a theme that did come up in both the presentations, which is that of people with predisposing risk factors. And this question is from Dr. Andrea Furlan from the University of Toronto in Canada. Do you think that patients with fibromyalgia that were stable and doing well before getting COVID were at a higher probability of having an exacerbation of their fibromyalgia? And if that is the case, what can we do to help protect people with fibromyalgia so that they don't have an exacerbation post-COVID? I'll let you each jump in if you have any reflections on that, or if you had a subgroup in your cohorts with fibromyalgia. Dr. Batista? Oh, sorry, go ahead, Dr. Knox.
No, please.
Please.
We didn't look at this specifically in our cohorts. We did look at patients with chronic pain presentations. And primarily, we found them to be sporadic across all aspects of pain presentations. However, fibromyalgia and the inflammatory components associated with it was something that's been looked at as well. Again, no major research has been assessed by this. However, patients of my own who have had this inflammatory aspect, as we talked about with the ACE inhibition, the ACE2 receptors, the inflammation component of it has absolutely exacerbated the pain presentation. In regards to, I think the last part of the question was, how can we prevent it or treat it? Is that correct?
How to prevent an exacerbation of fibromyalgia post-COVID?
I don't think I have a strong answer for that in that aspect of it as well. But as a lot of patients that I've been speaking with in regards to, with another concept that's come up now, is people are getting concerned about the response to the vaccine as well, and whether the exacerbation that we see with the active infection and with the vaccine, which we have all found now recently to be causing a worsening of inflammatory disorders. The concern is about patients with fibromyalgia getting the vaccine, that same kind of concept. Realistically, the preventative aspects of COVID-19 will be the biggest aspect we can do with it. However, if these patients were to become sick, though, the treatment and the actual processes we just discussed throughout the day itself would be much worse for the patient as well. So in regards to the answer, it's not well worded, but realistically, there's no major prevention or treatment for someone, particularly with fibromyalgia. However, just the preventative aspects of the infection itself. But this is something I've struggled with personally as well, and particularly with patients and friends of my own asking me about, attaining the vaccine and worsening of inflammations and inflammatory disorders.
Okay, thank you.
I totally agree with Dr. Knox, and I don't think there is a specific strategy to this, but I think it's important that people can map very closely their symptoms, because it's always hard to see the psychological or psychiatric background of the symptom, because we are mixed with our psychological functioning. So, and it's very common that the persons don't see that being locked down increased psychological symptoms and consequently pain and fatigue and so on. So I think to map and to discuss with other people what they are living may help.
Okay, thank you.
Um,
Oh, yeah, go ahead.
Sorry, Ian. Another aspect though that did come up in my practice is some people were avoiding their medications. And as I spoke to in my presentation, there's been no research for the antidepressant, anticonvulsant therapies that are often used with, such as fibromyalgia. So that aspect of maintaining therapies and getting the COVID vaccine should also, and the infection itself should be in place as well. Again, it's not preventative treatment, but I have noticed that some people were avoiding certain treatments, which has been refuted and has not been recommended by the CDC.
Okay, thank you. To everybody in the audience, as you know, the virtual environment is not as interactive as it could be with a live presentation, but I was just going to say, we're continuing to monitor the questions that are rolling in. So Dr. Furlan, if you have any responses or any strategies that you have been considering at your center in terms of how to prevent exacerbations of fibromyalgia, we would love to hear them. So if you type them into to the question screen, we can share that with the group. We have a question from Stefan Golick, who is a chronic pain pharmacist in Sonoma, California. For patients on chronic opioids experiencing new or exacerbated pain from COVID-19, have you noticed increases in opioid being helpful, or if any non-opioid therapy has been more helpful than going up on opioid dose? And if so, is there a duration of time for which an increase in baseline opioids has been helpful? So essentially, in an environment where we're trying to taper or at least control doses of opioids, we have potentially an event here where we are expecting an increase in pain, and how do you navigate that with respect to someone who's receiving opioids? Nigel, you want to tackle that one?
Oh, I'll go after that one. Yes. So that's always been a concern, especially with the evidence that we are aware of in the immunosuppressant effects of chronic opioids that's been out there in regard to the morbidity and mortality associated with chronic opioids. Yeah, absolutely. We did actually see that in some of our patients came in, patients with, I'm going to use one patient population and I don't mean to generalize, but the patient with sickle cell disease who were on chronic opioids and came in and there was an exacerbation and a further requirement. Again, after a period of time, we did not find that an increase in dosing or frequency was effective in providing relief. So that, as we usually would, that multimodal approach and having a look at the patient's pain etiology was a fact we did come through with this. Now, in our study, we did look at all the other therapies, the non-opioid therapies, such as ketamine as well. Realistically, the factor and a lot of the concerns at the time in acute respiratory distress, ketamine itself doesn't have an effect on the respiratory component, but as I spoke to, that it has this direct cardiac depressant effect. And in patients with catecholamine depleted, we had a lot of these patients in the ICU, and it was a concern for us as well. It's an effective therapy, but I think in a hospital setting, I think it's a great option for that to avoid further opioid increases in dosing frequency. Another aspect, again, and this was just a case review and study discussion, was tramadol itself, again, as we talk about as not being the mechanism of actions itself. And as we talked about in my presentation, the effects it has on the inflammation and the cardioprotective aspects. Now, no major research has been put out in regard to that. It was something that I just took interest in because, as your question goes to, we are very limited in the armory we have in the pharmacological approach. So we are trying to balance that patient safety while at the same time providing the relief of pain as well. So no strong answers. I think the best way to approach it is to look at the etiology of the pain, look at the patient's previous history as we always would, and look at the systemic components of the disease itself, which was very variable. That was another aspect. We always talk about the mechanisms of action in regard to the patient's metabolism with liver and excretion with kidneys. Each COVID patient that I saw, it was never the same. It was never just respiratory and liver and kidneys. It was very individual in the presentation. So the subjective approach with the armory of the pharmacological approach that we have is the best approach. But realistically, I didn't find that the increase in opioid dosing ever provided any benefit. And I found it made the providers very uncomfortable, particularly people with such poor respiratory reserve and on oxygen.
Okay, thanks. Abraham, I suspect you don't prescribe opioids yourself, but I don't know if you tracked opioid use in any of your studies and whether you had any comments about that question.
No, Ian, I'm going to skip this question as
Yeah,
I'm not a
okay.
specialist.
Yeah.
I don't prescribe, and Dr. Knox is a strong specialist.
Yeah, no, that's perfect. That's fine. Thank you. We have a question, something that I was thinking about as well, a question from Shahid Chowdhury. Do you think that there is emerging an overall change in the behavior and response to pain in people with COVID? And he goes on to say that he or she, in my district, some of the people are becoming insensitive to pain. If that's something that you're also observing, could there be an explanation for that?
In my view and my experience, people are getting more sensible to pain and not less sensible to pain. I also follow up rheumatological patients in a rheumatological outpatient service with more than 1,000 patients, and many of them are now more sensible to pain. So it's not my observation that people are getting less sensible to pain.
So to the answer to the first part of the question, I believe that the approach and the mind frame towards pain in COVID-19 has drastically changed since the very first time when we saw it in early February, March, when we were first seeing these patients. I'm embarrassed to say pain was an afterthought. It was more of a triage of more serious conditions in regard to respiratory, cardiac, and such. So realistically, pain really was not asked for. Our pain management team was primarily a COVID hypoxic response team. We were on the floors managing respiratory distress, and pain itself was not a major factor for us. Embarrassingly, I say that as a pain management doctor. But at that time, it was so uncertain and so unpredictable, and we didn't know what we were dealing with at all. So we were using a lot of previous research to look at previous viral illnesses, ARDS to deal with the lung component of it. And we were learning so much, and everything was so dynamic. It was changing. Within a 5-day period, we were going from everyone should be intubated to don't intubate anybody. So it was such a dynamic field. I feel that we're really undertreated and underrepresented from the pain management component. Compared to now, we know so much. Even when I reviewed for this presentation, there's so much research now about COVID and pain, the post-COVID, the PACS, the sequelae associated with it. There's so much more information and knowledge, and presentations like what we're doing today, learning more about it as a community is how we have more control and more certainty in our treatment plans. However, it's still such an unpredictable disease, as we see with the variants. So I think it's so difficult to be able to treat something that's so dynamic. However, I feel that we're in a much better place in regard to the treatment approach. On the second aspect, in regards to sensitivity, I actually I've seen patients have an increase in sensitivity, not such as much as insensitivity to it. So again, I haven't researched this by any means. This is all just subjective, me seeing in my own practice. But I have seen a sensitivity of pain with some of my chronic pain patients with inflammatory disorders who are getting the vaccines and who had previous COVID infections.
Okay, thank you. I should take the chance. We've really had a lot of enthusiasm and questions from the audience, but I'll just take a break for a minute and ask Abraham and Nigel if either of you have any questions for each other based on hearing your presentations.
Yes, I have one for you. I actually was very fascinated by your presentation because it was such an important factor during the infectious process and afterwards as well. And it was something that was just so undertreated in regard to exercise. Obviously, we were trying to cut down people that were seeing, providers who were seeing patients in the hospital. So nobody was getting physical therapy. And then post discharge, these patients were not having physical therapy, and 6-7 months before they were getting back into physical therapy. So you did mention the videos. I think it's very important. Do you have any ideas of how we could approach this? God forbid we go back to the levels, and some places in the world are still at these levels. How we could approach this in these patients that are in these isolated kind of periods, and how would you approach supporting them, particularly with such limited provider interaction?
I think this is the problem. This is a long-term problem, because even before COVID-19 pandemic, people who don't like to exercise don't exercise, and people who like to exercise. And in the majority of the studies, the big problem is how to make people that don't like to exercise. And I have a colleague that studies sedentary behavior in elite athletes. And it was very interesting to me, because he said me, they train for 3, 4, 5 hours a day, and then they come to their homes and they stay seated or laid down watching television, and they have sedentary behaviors. And he started to try to break this sedentary behavior by interrupting this state of sedentarism at home. And it is very interesting, because all the people, even people who don't like to exercise, can break their days walking for 1 or 2 minutes or doing something at home. And I think this may help people who don't like to exercise to manage their symptoms. It's quite different from if you stand up and walk for 1 or 2 minutes, even each 30 minutes or 1 hour. And in the opposite, if you stay laid down or seated or in front of a computer or something like that at home. This is very simple to do, and I think very interesting to help people at their homes now. And this is going to make people who don't like to exercise to do something.
Great, thank you. How do you have any questions for Nigel at all?
Yes, sure. My question is about opioid tolerance. We know that this is a very important problem, and how to deal with this problem when people are at home using opioids as they want to use, and this may help to increase pain and not decrease. Is it right?
Absolutely. So if I just kind of summary, like, it's how do we deal with the opioid tolerance associated with these patients with the chronic pain post-COVID, would you say?
Yes, sure.
So absolutely. And I think that unfortunately, a lot of these patients don't get to see a specialist in that aspect. And I think that the primary care providers are just so busy and they're so overwhelmed. They've done a fantastic job dealing with all of this. So they are managing this aspect as well. Realistically, like any patient with opioids, we always want to reflect on the progression of the disease, progression of it, and where we're going with it. The plan and continuation of therapy should never be structured around an isolated aspect. It should always require review on a frequent basis. And we often have patients on opioids that require coming in for repeat prescriptions. These assessments shouldn't just be for refills. It should be a reassessment of the patient's progression at that time. The goal should always be for titration as tolerated. It can be done in this isolation, kind of working in the silo. We have to look at the patient's progression. So as I said, I have a lot of patients that 6-7 months, it's marathon runners that are still requiring oxygen, that still have fatigue. It's that same concept with pain. We don't understand necessarily why these patients have these long-term neuropathies or continued inflammation post. So the therapy itself shouldn't be looked in the isolated aspect of how the opioids work and what they're doing. It should be, where is this patient going and how are they progressing? In that aspect as well, that we still want to return to that biomedical model. We want to look at the etiology of the pain. What kind of pain do we have? As we said for the presentation, there's so many factors compared with it: the vascular inflammation, the inflammatory process, the neuropathic component, the central nervous component. So opioids themselves, they work, whether they work everywhere and who they work for everyone. It's not necessarily treating the problem. So I always try to look at the etiology and try to maybe titrate with the utilization of other therapies that are more directed to the pain presentation. But it's an issue, it's an absolute issue that, you know, it's very difficult for a lot of people. And again, to speak to a specialist and someone that could focus on that in a time when they're dealing with so many other things, it's very difficult. And I completely understand it.
Thank you.
Okay. Well, I think these have been excellent presentations, very helpful to the community. I think we had a very well-rounded discussion. I just want to mention to the audience that the recordings of these presentations will be available in about three days on PERC, on IASP's Pain Education Resource Center. So you'll be able to access them or tell other IASP members that they can watch them. And I want to send out huge thanks to Abraham Bautista and Nigel Knox for wonderful presentations. And thank you all for attending. And hopefully you can enjoy the next webinar that's coming up in just a few minutes. Thank you very much.
Thank you.
Thank you. Thank you, everybody.